Chairman Collins, Ranking Member Casey, and members of the United States Senate Special Committee on Aging. Good morning. My name is LeighAnn Howard, and I want to thank you for this opportunity to speak to you today to share our experiences as a provider of home health in rural America. I currently serve as the Director of Home Health and Specialty Programs at Northern Light Home Care and Hospice, which is a Medicare-certified home health and hospice agency. As a member of Northern Light Health, a Maine-based integrated health care system, our home health and hospice programs provide care throughout the entire state of Maine. Maine citizens are among the oldest in the country and living in large rural geography. Over the last year, Northern Light Home Care and Hospice clinicians drove over 3 million miles to provide care, making close to 200,000 home care and hospice visits. At times, the transportation to get to these patients' homes is just as unique as the geography of the state of Maine. For example, to serve many of our island communities off the coast of Maine, our clinicians need to travel by lobster boat or mailboat, as this is the only way to access the island. And this time of year, our staff may have to shovel their way down a long, snowy driveway to reach the front door. Traveling the winding back roads and unpredictable weather conditions of western Maine also brings another layer of challenge. And many times, the travel time between each patient can be an hour or more. As Maine's rural population continues to decline, so do the number of qualified healthcare professionals. Healthcare workforce shortages have reached critical levels in our state. Not only do we experience a significant nursing workforce shortage, but also in primary care physicians. Nurse practitioners many times are the only primary care clinicians in our rural areas. Unfortunately, federal law prohibits those nurse practitioners and physician assistants from ordering home health services. Recently, we received a referral for a patient who had just been discharged from the hospital. He needed home health and physical therapy services. We worked for over 2 weeks with the patient's nurse practitioner to try to find a physician who would sign for the home health care that he needed. Some patients are even readmitted to the hospital before we can even find a physician who will sign for the plan of care. Rural residents already face many challenges to accessing the care they need, and it's important that we remove those barriers to be able to allow them to access health care regardless of where they live. Recent changes in Medicare brought on by PDGM have driven home the importance to us about collaboration between our home care staff, patients, physicians, and our patients' families. We are focused on how technology helps us to achieve the best collaboration with all of them. To focus on this, we've realized a significant success with our home telemonitoring program. This service places technology in the patient's home where they check their weight, their blood pressure, and their heart rate. That information is then transmitted to a web-based portal, either by cell signal or by the patient's home Wi-Fi. This information is then reviewed daily by the nurse. The telemonitoring nurse can then act on those readings, whether it's calling the patient to investigate the symptoms further, calling a physician, and collaborating with the physician to make medication adjustments, all while the patient is still remaining in the home. Our telemonitoring program has realized a rehospitalization rate of between 2 to 4%, which when compared to the national average of 24% rehospitalization rate for heart failure patients, is a significant improvement. One patient we have been seeing for a number of years, before coming onto a telemonitoring program, had over 20 ER and hospitalizations over the matter of 6 months. While working with our home care clinicians, our telemonitoring program, and our physicians, we were able to significantly decrease her rehospitalization rates. And most importantly, we've kept her in her home for over 5 years. Telemonitoring services are not reimbursed by Medicare, but it is allowable in the episodic payment for home health. However, we need to always continue to move to discharge with those patients. And with that, we need to remove that equipment that is in the home, which then brings that patient to be at a significant risk of being readmitted to the hospital. We're removing a device or a product that is helping us to be able to identify symptoms early, treat them in the home or in the physician's office and out of the ER or the hospital. Connectivity is also a challenge in our state. There are significant areas with little to no cell coverage, poor or no broadband access, and sometimes the cost of those services is just more than a patient can afford. And this also prevents us from continuing to move forward with video-based home visits. Other services that we think would help to keep our patients in their home longer are home-based pharmacist visits, as many of our patients experience polypharmacy, taking more than 25 medications. Again, I am so honored to be here today to be able to share our work with you, and I just thank you for this awesome opportunity.